Nobody knew anything about the heart. Nobody knew anything about menopause because nobody's ever studied it. And it's time for us to talk about that, time for us to understand it.
Well, this is why I wanted to have you on.
You have just given the physician, the nurse, or the other staff something to think about.
Okay, wait, is this different for women than it is for men?
The first heart attack of a woman is more often fatal than the first heart attack of a man.
There seems to be a bigger conversation.
Turns out that these episodes are actually markers of heart disease.
That's important. That's the missing link.
We are going to throw ourselves a siesta.
Yes, I'm going to start planning it now.
Everybody deserves to have the conversation. The next time you go for your physical exam, you ask for an...
Ooh, that can be a game changer. This is the Weigh In with Gina podcast. Joining me today is Dr. Jayne Morgan, who is a highly distinguished cardiologist and medical expert with a focus on women's health, particularly during menopause. Her extensive background includes roles such as Vice President of Medical Affairs at Hello Heart and Executive Director of Health and Community Education at Piedmont Healthcare. Dr. Morgan has also been recognized among the top 45 women's health experts over 45, highlighting her contributions to the field. I mean, I could go on. I just feel so honored that you have taken the time to join us today. Hi, hello.
Hi, hello, Gina. And I feel honored that you have selected me. I mean, your podcast is fabulous. So here I get to be actually on it. So I love that.
Well, let's talk a little bit about you. Why cardiology, and especially with this focus on women's health?
I chose cardiology a long time ago, did my residency and my fellowship. And, as I matured in cardiology, I began to see, a lot of differences in the way that we sort of addressed women. When I say addressed women, not necessarily the way that we spoke to them, but the way that we addressed their care. The language that we use, the way that we spoke with each other. And this was even just formal language, even how we characterize chest pain. Some chest pain occurs more frequently in women than men. And the chest pain that happens to occur, and I'm calling it chest pain, it's more of a chest pain equivalent that occurs in women, is always denoted as atypical chest pain. Whereas the symptoms that we know of, like the crushing chest pain, shortness of breath, sweatiness, that's considered normal chest pain for a heart attack. And that's really what men have. But as it turns out, as I was doing my fellowship and also becoming more seasoned as a cardiologist, I realized that more and more women are often denoted as this atypical chest pain. And I began to think, why do we have the atypical chest pain? There's a number of reasons for that. Meaning we may have nausea, we may have fatigue, we may have back pain, we may have jaw pain, you may have stomach pain, we may not have this crushing chest pain, but we are the majority of the population. We're 51 point something percent of the population. So how did our symptoms get to be atypical? So these are the kinds of things that they just didn't make sense to me in my head. And so I really, as I have matured throughout cardiology and developed some confidence, developed some power, developed some levity, feeling more comfortable speaking up and advocating for others, I've started to address these things.
Well, especially as we get older, I'm going through menopause myself now. I'm about 5 months in without my cycle. And there was a time where I was having heart palpitations and I was thinking, oh my goodness, am I having a heart attack? This goes back to when I was younger and I was watching Grey's Anatomy. And I don't know if you've heard or ever watched, there was an episode where Dr. Bailey knew she was having a heart attack, but she went to the hospital and they just kind of dismissed her. And they're like, nope, you don't have the typical signs of a heart attack. And I remember thinking then, okay, wait, is this different for women than it is for men? And I had no idea. And especially now as I'm getting older, it's just as prevalent with women as it is for men. And it's not really out there. It's not really mainstream conversation. Why do you think that is?
Yeah. And first of all, I will say 5 months in, if you make it to 12 months without a cycle, you are officially in menopause. And Halle Berry has decided that once we enter menopause, we should all have a party and we're going to call it a siesta. And we are going to throw ourselves a siesta for freedom and empowerment. So you are 7 months away from that. So yay, yay, yay. Don't forget your party.
Planning it now. I'm gonna start planning it now for sure.
Yeah, palpitations, actually, I also suffered from palpitations. And as a cardiologist with zero training in menopause, I mean, zero, that I began to have palpitations and I went to a cardiologist. I didn't know anything about perimenopause, didn't know anything about menopause. Neither did the cardiologist who saw me, who also then referred me to another cardiologist. I underwent a giant workup. No one could find anything. I ended up being diagnosed with mitral valve prolapse, a mild degree of mitral valve prolapse, which
Yeah.
another diagnosis that is more commonly given to women, ascribed to women, which is fine. But mitral valve prolapse is sort of a throwaway diagnosis that we use within cardiology that can mean a number of things. And oftentimes it will be the reason for she's hysterical or she's having a panic attack because she's got this mitral valve prolapse. So I ended up with
Right.
this diagnosis of mitral valve prolapse, which is an actual physical diagnosis, but generally is asymptomatic. And it has been ascribed all of these emotional attributes. And so you generally don't see those with men. So just another, layer. So I had mitral valve prolapse and was like, oh my God, I guess I'm just one of these crazy women who's just having a panic attack and falling apart. And now I've got the mitral valve prolapse, disease. And literally, I still didn't find out until years later after I started to educate myself on menopause. It was one of those things that I had for a while and it went away and nobody ever found a reason for it.
Yeah.
It was just that panicky female doctor, that hysterical female doctor who put her heart into an arrhythmia. Those kinds of things just started to annoy me. First of all, I'm probably the least panicky person that not a panicker, right? Most people who go into cardiology are not panickers. But you still buy into it. It's like, maybe I'm more stressed than I think. Maybe I'm internalizing. Maybe, it's just, you drive yourself crazy over things that quite frankly are nonsensical. I was not having a panic attack, right? I was going through perimenopause and I had palpitations. And the reasons you didn't know that is because nobody has studied palpitations and perimenopause. And the reason for that is because no one does clinical trials and research that is focused on women outside of the reproductive area. But guess what, everybody? Women have hearts and brains and livers and kidneys and arms and bones. So nobody knew anything about the heart. Nobody knew anything about menopause because nobody's ever studied it. So I was just another hysterical woman. Although inside, I know I'm totally, totally not hysterical. I mean, I'm the
Yeah.
person who watches movies when women trip and faint. I just turn the channel. I can't deal with it. Cannot believe another woman has fallen and lost consciousness. I'm not dealing with a fainter. Sorry. So
So what do you think of the I love this because you are so smart and educated and absolutely brilliant and yet this is your experience.
right.
Is this where you're I know you do your stairwell chronicles.
Stairwell Chronicles, yes.
Yeah, and so is this sort of like was that born out of this passion to kind of clear the air? What
Just educate. Actually, the Stairwell Chronicles were born out of another need. So, in addition to women's health, when we look at global populations and minority populations, the same thing
Yeah.
in healthcare. There are all of these biases and little things that are sort of attributed to different groups that are just nonsensical. So,
Yeah.
that was born out of the COVID pandemic when I decided that I needed to just sit down and begin to explain COVID and explain vaccines really to all communities in a way that was understandable, not scary, not panicky, not threatening, but like a sister, a friend, a neighbor. You can relate to me, make it very simple, short. It's only 60 seconds. And that's really how it started. Let me just talk to the public in a way that they understand. They were reading things with the CDC, but they couldn't really understand that it was too scientific, or they would jump into conclusions or misinterpreting one word that means one thing to the layperson, but actually has a different context when it's in a scientific context. And so I really took it upon myself to sort of be the intermediary to begin to explain science. And I started with COVID and then began to transition into these other areas in which I'm very passionate and I'm very focused on.
Yeah, and if you're watching or listening to the conversation, you can head over to Dr. Jayne Morgan's Instagram account where you will see her stairwell chronicles. And it's really about sharing her expertise with these really heart-led conversations. Okay, so you
Yeah.
wear many hats: cardiologist, medical executive, educator, advocate. What keeps you grounded? And in the program, I talk about being connected to our why, our mission. Like what keeps you grounded and really connected to your why?
Yeah. And I will say, speaking of whys, there is a Y in my first name. The most common reason that people can't find me or that I miss emails, people spell my name Jane. It's
Yes.
Jayne.
Good to
So
know.
that's my why is that I
Yeah,
have to
yeah,
have a
I love
Y
it.
in it.
I love it.
But the other thing is, I think sometimes to give a voice to those who it's hard to find your voice. And listen, and I'm telling you from experience, I am a part of the system, of the medical system, and yet I'm also not a part of it. I'm a Black female, so I've got one foot outside of it, one foot inside of it. And so I
Yeah.
know what it means. I know what it means to see a doctor, even though I am a doctor. When I have been sick and I've been in the hospital, I've been in the emergency room, or I've had to be at the doctor's office, trying to challenge your physician or your colleague or give a different perspective when you're not feeling well or when you've been taught to respect the institution, respect the physician, or even or females not challenging a male physician or a male attending or treading more lightly because they may erupt or they may these kinds of things. And I have had to really teach myself literally. And when I say literally, I mean this year, last year, if I have to go to the emergency room, I have to give myself a pep talk. The doctor will come in. I already am thinking about what I think is going on. I'm a doctor. I've got ideas.
Yeah.
I'm thinking about what's going on. The doctor will come in. Sometimes he already knows me. Sometimes he doesn't. Sometimes he or she is a friend. Sometimes they're not. And there have been times when they have said things that are different than what I think, which is okay because they are the attending physician. That's why we should never treat ourselves. But then because they've said something different, I stayed quiet when I came in there with all these thoughts and I let them leave. And then I have to go, darn. I need to speak up for myself just because I'm thinking something differently. And so then I have to ring the bell and have them come back in and give this pep talk of here's what I think. And to them, it probably looks as if we're having a professional conversation. But the fact of the matter is, I just gave myself a pep talk because I let you leave the room and I didn't say
Wow.
anything and I didn't
Wow.
challenge you. And imagine if someone in my position as a
Yes.
cardiologist is struggling with that. What someone without my medical background, how easy it is to just yes and nod and best. I don't know anything about science. Whatever. I do this, I do that. I'm a hairdresser. And you just go with the system and you really don't know. And you've been taught not to challenge authority. And the man walks in and he's in charge, even if he's clueless, right? We still think they're in charge. And it's taken me a long time to challenge that. And I went through my training, and quite frankly, I knew more than some of the attendings. I knew the answers to questions that I didn't give the answers to because I didn't want to appear to be showing off. All of that is nonsense. And it's taken me an entire career to get over that. When I tell you, I'm talking about this year, last
Yeah.
year, I still have to give myself that pep talk. And so, because I struggle in a male dominated society, in a white dominated society where we're taught to be deferential, we're taught to be respectful, I try to give a voice to others whom I know if I'm struggling with the culture that we're brought up in, then others must really be struggling when they don't even have the knowledge that I have. So I try my best. But it's my personal struggle as well.
I really appreciate you being, I don't know, vulnerable is truthful, honest, about your experience. I think because so many of us function, well, I just try to stay in my lane. I don't
Right.
know any better. Plus, I want to put faith in my doctors. And,
Mhm.
from the conversations I've had, especially with menopause and going back to that conversation, there wasn't a conversation. It was kind of something
Mhm.
skipped over in
Right.
medical school. And what
Right.
do you think of that conversation now? And is it different for women of color? What is the conversation
Yeah,
there?
and it's not even skipped over. You know, skipping over something means that it's there and you've moved on to something else. Like
Right.
it's not there. It doesn't exist. There's
Yeah.
no, it doesn't exist. I had certainly heard of menopause. I knew what menopause was. I had no idea that it had any business in medical school. Like, what is there medically relevant about menopause? I mean, that's how
Yeah.
ignorant I was because I'm in a system that is teaching me by not teaching me that it's irrelevant. We're not skipping it, it's not even here, right?
Doesn't
So
exist.
I've
Yeah.
had to learn and teach myself and learn from other colleagues, and we teach each other, and we do a lot of reading, and we compare patients, and we learn the data on estrogen. We debunk trials, and we really have had to form an alliance to really move this forward as a group to move it forward. And that's really where it's born. Now, ultimately, we now know menopause has a lot of medical equivalents, including cardiology. In fact, cardiology is without question the most serious consequence
Yeah.
of perimenopause and menopause,
Yeah.
having a heart attack, having a stroke. And it's time for us to talk about that, time for us to understand it. It has to be a part of the medical school curriculum such that medical students come out learning it. Internal medicine residents know it. Cardiology fellows know it. OBGYN residents know it. As opposed to now, what am I doing? I'm talking with my colleagues, and now you're dealing with the horses out of the barn. You've got to unlearn something and then relearn it in a different way. And it's completely foreign and it's difficult. Remember, this is something that did not exist. It doesn't exist in hospitals, in doctor's offices, in medical establishments, other than the exception of, oh, you're in menopause, I'll give you an antidepressant or
Right.
give you something for anxiety. Same with my
Right.
mitral valve prolapse. You must be having a panic attack. You're just a nervous woman.
So let me ask you this then. Are people missing the conversation, the heart health piece when it comes to
I
menopause?
think people are. And
Yeah.
as far as I can tell, I'm really still one of the only cardiologists, not the only one, who really, really, really is bringing a hammer down on this nail regarding
Yeah.
cardiology and heart disease. I mean, I'm right out there on the forefront, really pushing it. And part of that is I have a big background in clinical trials, a big background in research. I've done a lot of work in health equity and women's health, written a lot of protocols, have traveled the world giving lectures and things for all of these drug companies, including AbbVie, Solvay, as I worked. And so I understand what real R&D is, research and development, when you are developing drugs and devices for companies such that they can go before the FDA and be approved and go out to global populations. That's literally what I did. That was my job. And so having that understanding of where these drugs come from, even before we began to prescribe them. What that means is who's in these trials that we're prescribing these drugs for. So I had that granular level, not only of information, but experience and expertise that almost no doctor has. Most doctors are not spending their time in the pharma industry and device industry developing protocols. And quite frankly, don't necessarily think about where the drugs come from. What are we taught? We're taught to learn all the effects of the drugs. Once we have them, we have to know where they work, where they don't work, what are the side effects, what are the interactions. We don't really give a lot of thought to how it got here.
Yeah.
We've got to use it now, and we've got to be able to use it very effectively and very safely. So it's a different part of science, that I needed to bring also to the forefront that most doctors lack. And so it was in a unique position to really start to connect the dots and bring it forward.
Well, this is why I wanted to have you on. Everyone's talking menopause and the symptoms and, HRT for
Mhm.
treating the symptoms. And I was like, there seems to be a bigger conversation
Right.
here that we need to talk about, which is truly what our heart health.
That's right.
Um, what what do you think is the conversation when it comes to menopause and heart health?
The conversation is that menopause is not innocuous. Menopause is not a ha ha ha, look at her having a hot flash and she rips off her jacket and then she feels better and she puts it back on. And even women laugh like, oh, I survived another one, and everybody fans and, that type of thing. Turns out that these episodes are actually markers of heart
Yeah.
disease. We're actually watching a woman tell us that my risk of heart disease is increasing.
Wow.
That's what we should be reading when that happens. When a woman has hot flashes or night sweats, starts to gain weight, that belly weight, or dry skin, including those itchy ears, change of taste in the mouth, abdominal pains, weird abdominal pains, all of these things. There are so many symptoms of perimenopause that we're not even taught. And not only do we need to be taught those symptoms, the reason we need to be taught them is this not to be dismissed, it's not to be laughed at. It's such that doctors can say, this woman is whatever, between 35 and 55 years old, and she's telling me that her ears are itching, and she's telling me she has vertigo, meaning that the room is spinning. Instead of sending her to a neurologist, as I was sent, because I also had vertigo. So I went to a
Same.
cardiologist for my palpitations, a neurologist for my vertigo. The fact of the matter is, I was in perimenopause. Nobody
Yeah.
knew. So instead of doing all of that, not only do we need to understand what's happening, but what we really need to be thinking is this woman is telling us that her risk of heart disease is increasing. So I need to be very aggressive about managing her risk factors. I need to make sure her cholesterol is down to goal. She's smoking, she's got to stop. I have to get her on a good exercise regimen, including resistance training. I've got to make sure her blood pressure is down to goal and it stays down. Maybe she even needs a home blood pressure monitor. Those are the kinds of things where I may need to put her on a statin or cholesterol lowering drug. I need to have a talk with her about hormone replacement therapy. Maybe that is right for her. Maybe replacing the estrogen and controlling the symptoms. All of those are not for comfort. And let me be clear, there's nothing wrong with comfort, but I'm talking to you as a cardiologist. We're,
Yes.
we should stop thinking about that we're doing it for comfort. We're
Comfort.
doing it because this woman is telling you that her risk of heart disease is increasing. That's how you should be reading the itchy ears, the vertigo, the stomach pain, the dizziness, the palpitations, the night sweats, the hot flashes, the rise in cholesterol, the belly fat, the sleeplessness. That's what you need to be thinking, not, oh, let me prescribe something to reduce your anxiety. Oh, or maybe I can just, help you sleep. Nothing wrong with sleeping because good sleep is very restorative. But we
Yeah.
need to be thinking about the cardiac risk, including your risk of stroke and that connection of the heart and the brain. That this woman is telling you that her risk of heart disease is increasing and that there is a connection to the heart and the brain. And here's an opportunity, doctor, for you to intervene now and protect me from having both a heart attack and or a stroke. That's the change in the thought.
Well, you're such a huge advocate for diversity and especially women of color. Is the conversation different? That do they have to pay particular attention?
And the conversation is not different per se, but the symptoms can be different, meaning very cruelly, symptoms can be more prolonged, especially hot
Uh,
flashes. They can be of longer duration. They can last for up to 10 years.
right.
Often white women's symptoms can be much shorter, 3 to 6 years. Asian women, maybe, around the 6 to 7 year mark, but Black women can be up to 10 years. And so that's why that conversation should be different. Because remember, I just talked about how symptoms are actually markers for heart disease. So the longer you're having symptoms, the more we are watching your risk of heart disease and stroke increase. And so we need to understand how we are connecting symptoms to cardiovascular outcomes and to brain outcomes
Is it
outside of
length?
depression and anxiety. And I want to say, I definitely recognize that many people can have depression and can have anxiety. Those things are real. I'm
Mhm.
only saying that all perimenopausal symptoms are not caused by a woman who's depressed or anxious. That's all that I'm saying.
I had many of the similar symptoms. I had vertigo, frozen shoulder, heart
Mhm.
palpitations, heartburn, like you name it. I had all the things. I blew it off as I got edgy during COVID, maybe. I had a lot of stress. I was running a big business. My children's father was sick and then passed away. And I just kept
Oh,
blowing it off and blowing it off and
right.
blowing it off. I went to my doctor, and at the time, she prescribed me an antidepressant.
Mhm.
And then about a year later, I went back to her and she's like, you know what? She's like, let's have a totally different conversation. Because by
Mhm.
then she had gone and learned more about what was going on. And I think it's that really big, that education piece. Um,
Good for her for being progressive. And I'll tell you something, Gina, that you just brought to light beautifully. Women, the first heart attack of a woman is more often fatal than the first heart attack of a man, primarily because of the delay in care, the delay in recognizing it. And part of that delay is women also putting others before ourselves, putting ourselves last, dismissing our symptoms. There's always one more thing we need to do. And before we know it, we've had a heart attack. Because remember, we've got these atypical symptoms that may not warn us that we're having a
yeah,
heart attack, like chest pain and shortness of breath. We may be tired, we may have nausea or something like that. And we sort of put things off and put things off and put things off. Again, when I talk with you about why I'm doing what I'm doing, Gina, this is what I'm talking about. Our culture, the culture of the expectations of women, not only what society's expectations are of us, our expectations of ourselves that we have learned within the greater culture. And you
yeah,
just demonstrated that greatly. You had several stressors going on at once, including the death of an ex-spouse and your
yeah,
children's father, and you kind of kept going. You had to get to the next thing. You had to take care of your children. You had to keep moving.
yeah,
This is what women do.
yeah. And I was Googling, am I having a heart attack?
Right.
Rather than, I mean,
Instead
thank
of going to
goodness.
the emergency room or going to a doctor, right?
Yes. And so thank goodness
Did
it
I
was
stop? Am I having
perimenopause.
a heart attack? It doesn't look like, okay, let me keep going. Right?
Oh
That's a
my
delay
goodness.
tactic. How can I keep going? Let me just Google
How
it.
can
All
I
right,
keep,
it looks pretty
yeah.
good. Let me just keep going. Right. And
Yeah.
so we
Thanks for
those
saying.
those that's exactly it. I mean, you can't fight all of the culture and all of the societal norms and things that are normalized that should not be normalized,
Mm,
language that should not be normalized, expressions that should be normalized. So the best that we can do is advocate for each other and advocate for ourselves and make sure that we have information so we know when to speak up, we know when to stop. We recognize when we're in a vortex, okay, wait a second. I'm back to my same habits. I'm doing too many things, even though I know I have symptoms. I've been here before. Let me take a moment and do something differently this time. That sort of thing.
that kind of leads to burnout and then stress
Mhm.
because as we're aging and then you add menopause or heart health, where does burnout and stress factor into the conversation?
And burnout is such a big deal. And it's really a big deal in midlife women because as our estrogen levels drop, we have estrogen receptors, not just, on our breast, our uterus, our pelvis. We have them in our hearts, but we also have them in our brains. We got them on our liver, we have them in our kidneys. As your estrogen levels drop, Many women suffer what we're terming it brain fog. You have difficulty with memory, have
Yeah.
difficulty, remembering even the simple things, or you're feeling frustrated. You're having trouble finding words that used to be simple to find. It's taking you longer to complete tasks at work. In fact, a recent article showed that women have a 10% decline in their work life during perimenopause and menopause. At midlife, they actually step away from work because you feel as if you can't manage it. The reason you can't manage it is nobody's recognizing what's happening. And
Yeah.
so you burn out, you're trying harder and harder to do what you used to do. And then what? Then you also become depressed because you know something's wrong, but nobody's acknowledging it. Nobody knows what it is. You may go to a couple of doctors, nobody knows. And you're on this spiral, right? And so, again, talking about hormone replacement therapy may or may not be right for you, but everybody deserves to have the conversation such as you can make a decision. You and your doctor can make a decision together, shared decision making about what's the best course for you. What's best for your life that fits in with your values, your lifestyle, how you're trying to, whatever you're trying to live, and whatever your standards are. Have the conversation. It doesn't mean you have to take it. It's about knowledge and information, which is always powerful.
There seems to be more conversation and research coming out about the benefits of taking HRT for heart health, especially
Mhm,
as you get older.
mhm.
Thoughts on that?
Yeah, so some disparate thoughts. Part of the challenge with that is I came out of a research background. We simply don't have recent, let's say recent, last 10 or 15 years, randomized clinical trials, which are the gold standard, with women being enrolled and randomized to one arm or another, either hormone replacement therapy or not. That's the gold standard. The reason we don't have it is there's really no funding for women's research. Nobody's really interested in it. So, what's the next best thing? We look at older studies of randomized clinical trials from 1990s and the early 2000s and look at those results, and they do show that there's a benefit of estrogen. We look at smaller studies that are not as valuable because the numbers are so small, right? So
Right.
it's harder for that to be um, of credibility. We look at retrospective data where we're not doing a trial, but we go back and look at all of the data of 10,000 women, of 20,000 women, and make a comparison and put them into groups. So, in doing all of those things, that's where we've come to the conclusion where we're moving in the path of estrogen therapy improves your risk of heart disease. In other words, it decreases your risk as you go through perimenopause and menopause because estrogen is a cardioprotectant agent.
Right.
Estrogen is also an anti inflammatory, it's a woman's natural anti inflammatory agent. Chronic inflammation in the body that's caused by any number of things. We hear about it with processed foods and obesity and chronic diseases. Chronic inflammation in the body causes the progression of chronic diseases, including the acceleration of atherosclerosis in the arteries of your heart. In other words, plaques in your heart, plaques in the arteries of your brain that increase your risk of heart disease and stroke. That's what inflammation in the body does, chronic inflammation. Estrogen is our natural protectant, it is an anti inflammatory. So that is why prior to menopause, a woman's risk of heart disease is only half that of a man's because
Right.
we got that estrogen protection. And then when we go through menopause and we've lost estrogen, our heart risk of heart disease equals that of a man. And then after that surpasses it. And I think that it surpasses it because we still fail to recognize and fail to treat heart disease in women in a timely manner.
Because the signs are there that it is starting early. We just weren't really paying attention to it.
You know, I don't want to say we're not paying attention to it. We are aware of it. I think women are very in tune with our bodies. We don't have the information to connect the dots. No one has
Ah,
told us what this means. So we're
Right.
paying attention to it. We don't necessarily jump to the conclusion that we're having a heart attack because that's not what we've been taught.
That's
What
the
did you
missing
say, Gina?
link. That's important. That's the
Yeah.
missing link. We're noticing,
We are
and then
noticing
we're
women are very
saying,
in tune. We are noticing our bodies.
"Ooh,
What we don't have is the information, the next step to such that is an actionable step for us to be alarmed or to be worried or for your friend to be worried for you. And here is, the second concern. If you come to the medical establishment, let's say you Googled it and it said, "Hey, Gina, as a woman, you might be having a heart attack." And let's say you believe Dr. Google and you say, "Okay, I'm going to the emergency room." You get to the emergency room, the staff there may
yeah."
poo-poo you away and give you the term atypical chest pain. Whereas a man next to you who came in at exactly the same time, who's having chest pain and shortness of breath, has been sped off to the cath lab to get his artery open to save him from a heart attack. And you still sit there on the gurney in the emergency room because you're not having these sensational symptoms. And you're now having to try to convince the staff that you too are just as sick as the person who was whisked off to the cath lab, but your symptoms are presenting differently because in medical school, we are learned to recognize them differently and therefore treat them differently. That has to change. That is not correct. And that is why more women die.
And this is why we need to follow you over at
Yes.
Dr. Jayne Morgan, Jane with a Y. I mean, this is it. It's
That's my
about
why.
educating it's about educating ourselves and empowering ourselves, and thank goodness there are people like you that are out there that are sharing,
Yeah.
and in the hopes of empowering us. Before you go, what is one myth about heart health?
So here's a myth for women. And it is that women don't need EKGs, right? For most of our
No.
lives, we go for our physical exam. And what do we get? We get breast exams, we get pelvic exams. Then when we reach of age for screening, we go for mammograms, we go for pap smears, but we never get an EKG. Guess what the men get in their physical exams? They get an EKG.
What?
So what happens when we get to the hospital? We don't even have an EKG on record. So here's what I want you to do. The next time you go for your physical exam, you ask for an EKG, not because you're sick, but because you want it on your record. Such that if anything happens to you later, just like the man in the next room, we have something with which to go back and to compare. That's another reason that makes it more challenging to treat women because most men have EKGs on the record. We can go back and compare and actually see when the change occurred. Women don't have that. What do we have? We have mammograms and pap smears. That's not really helping our hearts. Women are not all about reproduction. We're not just a reproductive vessel. We have other things. And the number one thing that will kill us is heart disease. Heart disease is the number one killer of women. And the last thing that I will say to you is if you do feel unwell and you are in tune with your body, and you've gone to Dr. Google, and Dr. Google has told you, go to the emergency room. I think you might be having a heart attack, and you don't have symptoms that you recognize. Maybe you just have nausea. Maybe you just feel tired. And you go to the emergency room, and they are also dismissing you and are going to discharge you. I want you to ask the doctor to get an EKG before you leave. And that one request, you speak the language of the system. You don't have to advocate for yourself. You don't have to speak up. You don't have to argue. You ask for an EKG. Now you're speaking our language. It can't be refused. Your insurance will reimburse it. You're in the emergency room. And that EKG, if it is abnormal, will drive the rest of your care towards great cardiac care. If it is not abnormal, or let's just say, if it is not abnormal, you have just given the physician, the nurse, or the other staff something to think about. Just by you asking and requesting for that EKG, they now have to think, oh, maybe I should be thinking about something else. And then may keep you there and order some other tests. So try not to spend a lot of time advocating for yourself. Use the tools and the language of the system. Simply ask for an EKG. You now have communicated tons to the staff, and they will respond and communicate tons to you just by requesting that EKG.
That can be a game changer for
Again,
someone listening. My final question was the message that you want us to get loud and clear, and I think that about covers it.
yeah,
Dr. Jayne Morgan, JayneMorgan. You can find her over on Instagram, or you can go to janemorgan.com. Thank you so much for
thank
your
you,
time
Gina. I
today.
love being here. Thanks so much.